Oh, there we
No?
go. Yes.
No.
So you just need to share them in presenter view now.
Okay. Presenter view. Okay, that should be fine. Yeah. Hello, everyone. Thank you very much for having Emma and I to present today. We're both analysts in the PHM team at SNE-ICB, so that's Suffolk and North East Essex. And what we're going to be talking about today is just really a sort of quick fire view on how to do population segmentation with sort of strategic commissioning in mind. If we kind of just start with this first picture on the top left here, this is a footprint of Suffolk and North East Essex. And we have three main alliances within this. We have Ipswich and East Suffolk to the east, we have West Suffolk to the west, and North East Essex coming up from the south. Now, within this kind of footprint, there are approximately 1 million people, and the healthcare kind of cost of this group of individuals is about £1 billion. So it's very large. And inevitably, within this population, there's large variation in population healthcare needs. So some individuals will be at start of life and require maternity care. Others will require, may have short-term conditions or exhibit short-lived healthcare demand. Others might have characteristics linked to prevention, whereas some will be diagnosed with physical and mental health long-term conditions. However, there'll be there'll also be lots of complex individuals. There will be individuals with aging who have severe frailty, who may be multimorbid or even at end of life. And so if we're going to kind of develop a sort of model that helps our strategic commissioning across this entire footprint, we really want to generate a model that separates this population into distinct groups of individuals with shared characteristics based around life course. And this is what population segmentation is all about, really. Now, the kind of model that we've gone with.
Okay, I think that was me. So shall I hit buttons?
Yeah, please. Yeah, thank you.
Okay, are you happy with that slide, or should we move on?
Yeah, move on, please. Yeah, thank you. Great. So in terms of the design of our segmentation model, what we've aimed to do is split the population into children and young people. So this is not just 25-year-olds, and then the adult population. And within each of these age groups, further divide them into low, moderate, and high resource groups. We then try to separate them out into smaller levels of granularity across different segments. So you can see on the picture here on the top, we have groups who might be in maternity or healthy or might require early prevention, going up in high resource to moderate complexity and multimorbid or end of life. Importantly, the model here contains both physical and mental health conditions at different level gradients of severity, but one patient is put into one domain and one segment only. And this allows us to prioritize and is very useful for our strategic commissioning. Importantly, it's not just based around long-term conditions. We also have other elements within this, including prevention angles, maternity angles, holistic aging characteristics, and end-of-life care. Thanks, Emma. Next slide, please. Yeah. So the model uses a range of data, and at SNE-ICB we have lots of linked healthcare data. So every one of our practices has agreed to provide its patient level data, and this is linked to nationally commissioned data sets across our acute providers, mental health trusts, and community care. But we also use a wide range of other local data sets as well, and this is all very useful for how we kind of create the model itself. Thanks, Emma. So the model inevitably had lots of complexity under the hood, and I'm not going to go into the detail here, but this, for example, this picture here is the adult version of the model. So within each segment, there are lots of characteristics of our population that we define to be within that segment. For example, if we look at the multimorbidity high complexity segment here, we might define individuals who have 4 or more long-term conditions, or they might have hyperpolypharmacy, severe frailty, severe learning disability, etc. But we can do that for every segment in this adults model. Next slide, please, Emma. Thank you. Equally, we can do it for children and young people as well. So we can think about and ask clinical leads, what are the key characteristics that you want to know about in your population? So they might mention, for example, asthma or epilepsy or certain characteristics of children and young people, such as obesity or mental health conditions, and we can incorporate that within our model here as well. So you can see from the sort of model, from left to right, there's generally an increase in patient risk, resource use, and spend. But all very useful for how we can kind of think about the level of care that would be best beneficial for a population. Thanks, Emma. Next slide. I think this is your one. Yeah.
Yep. So if I pick it up, so really the important part of our model is that it's got to provide insights. So we're really looking at insights into the current state of population, what the health is of our population, how that's changed over time, what the impact is of geography, how these different elements within our model are connected within each other, how they cluster together perhaps. And also we're thinking about how we can evaluate our commissioned programs, because this is all about strategic commissioning. We have to think about whether our model is valid and if it is useful. So it has to support our strategic commissioning. That's what it's for. It needs to be clinically relevant. It has to be a clinically relevant model, and that's why we've had so much co-construction with clinicians in this model. It has to have reasonable size populations distributed across the different segments so that there is a sensible population size to act upon. It needs to be designed subject to data quality limitations. We have a lot of data and we're very fortunate to have a lot of linked data, but there are going to be things that we can't look at. And obviously as new data sets are brought in, we can maybe add some more things to the model, but at this stage we have to consider what we can't do as well as what we can. It needs to robustly demonstrate where we are as a system and the changes that have happened to our system in time. And of course, we also need to work in conjunction with other insights, so risk stratification, what we can do about change modelling. We have to consider how the model fits with all of those aspects as well. We need to think about how we then transform this analysis into impact. So we're very fortunate in SNE that our programme lead functions are strongly linked to our different segments. And so it means that this modelling connects through to our operational model. Each segment is ultimately real people. So real people with real NHS numbers, and we can drill down and we can re-identify patients if there is appropriate direct care that we can offer. We can also perform deeper dives within each segment and try to understand groups of individuals within the segment. Our approach is fundamentally aimed at standardizing work at different scales. And as we have all these different scales within our system, from GPs through PCNs, neighbourhoods, alliances, to the whole ICS, we've got standardization by using this model that we have developed. So looking forward, we're going to be moving into a bigger system. So, excuse me, we're soon joining up with our system across Norfolk as well. So the Norfolk and Waveney system will have a bigger population at that point, more providers. We're looking obviously at further development of neighbourhood health, and we're going to be applying our model across that combined population, and we're currently developing that through. Our model outputs will be embedded system-wide. They will be in our standard reporting. We can do things that are bespoke for deeper dives. We can re-identify for direct care. And of course, this is all about supporting our commissioning cycle, how we understand the health needs of our population for now and as we move forward, and how we create that link between our programme leads and our model insights so that we can commission effectively as we move forward. So thank you for listening. If you've got any questions, we've got Joe's email up there, and big thanks to the people within our team. We've got a great team and it has been brilliant to work with our team in developing this. Some key names on there that we're particularly appreciative of. Thank you.
Thanks very much, Emma and Joseph. And we just wait for some questions to come through on the Q&A, but I've got one to kick us off. So there's a panel session tomorrow that is discussing the fact that there's been a different case mix post-COVID of people at end of life, dying at home. So there's a 10% increase in numbers of people dying at home, but also an increase in the complexity of the case mix. So just thinking about your segmentation, you've got that end of life care segment. Does it allow you to drill down into, where people are dying, and so that you can think about that, how you support services to evolve over time in terms of deployment of where they go and how they're trained to support more complex cases?
Yep, absolutely. So in our kind of end of life segment, we can both look at those individuals who are flagged as end of life, but also those who may not be flagged as end of life, but have certain end stage characteristics. For example, end stage COPD versus end stage renal, etc. But as Emma kind of mentioned earlier, we have real NHS numbers under this, so we can link it to any kind of end of life characteristics that you want to look at. So that might include where people's choices around their end stage. Particularly, there are things like the My Care Choice register, which would define people's wishes as they reach that point. So yeah, all very possible to analyze, and of course we can analyze this in time to look at any variation that may have happened post-COVID. Thank you. Well, I think you might be on mute, Emma.
Sorry, thank you. Question in the Q&A and another one in the attendee chat. We'll only have time for one now, but please do answer the other one when you've gone off camera. But are clinicians involved in developing your dashboards, reviewing the data and using it?
Yeah, absolutely.
Yes.
Absolutely. So in development of this model, every clinical lead across the SNE ICB were presented this model at a workshop. And were given lots of opportunity to contribute, and we just iteratively developed this model based on their clinical opinion. But also, as we move towards a Norfolk and Suffolk future ICB, the Norfolk leads have also seen this model. So it's been a really, really valuable contribution from them, and has definitely strengthened the value of the model. Yeah.
Excellent. And there's a question in the Q&A before and after that one, so please do stay online and answer away as I introduce our next guest. Yes, thank you very much. A really enlightening talk. Thank you.